Hello, everybody. So this plenary will be on improving adherence. Until there is a cure, people living with HIV will need to endure years or decades on treatment. And for the health of people living with HIV and well-being, to control viral replication and to avoid drug resistance, it's important for them to be able to adhere to their treatment regimen. But that can be complicated and challenging. Dr. Parsons and Dr. O'Cleary will be talking today about interventions designed to help people adhere to treatment. They will also discuss what it takes to scale up proven interventions so that they can reach and benefit more people. We'll have the two presenters. Our first presenter will be Dr. Jeffrey Parsons. He's the editor of Sexuality Research and Social Policy and associate editor of the Archives of Sexual Behavior and AIDS and Behavior. Jeff has also been a member of the White House Office on the National AIDS Policy, HIV, and Aging Working Group, and chair of the Behavioral and Social Consequences of HIV Studies section of the National Institutes of Health. Please welcome Dr. Parsons.
Good morning. It's a pleasure to be here. I'm going to try to sort of walk you through kind of a series of research studies that we've been doing looking at improving HIV medication adherence among positive individuals in New York City. And one of the things that we really consider in doing this is how do we get to eventually something that can be scalable, that can be utilized in clinic settings rather than in a research setting, which is where we always start testing our work. So what I'm going to try to do is give you some information and some data on the first and so far the only behavioral intervention that's been focused on HIV medication adherence that resulted in positive both immunologic and virologic outcomes. Talk about the evolution of that project into a second RCT and a planned effectiveness trial. And one of the things that I like to do as a researcher is I like to point out when we screw up. So I'm going to highlight several mistakes that we made along the way of conducting the series of studies. So we focus a lot on alcohol use, which sometimes we refer to as the forgotten drug because it is often not considered as a major barrier or impediment to adherence or an issue for people living with HIV like more illegal or illicit substances are, but certainly alcohol is the most commonly used substance, and so we spend a lot of time focusing on the role of alcohol use and the health of people who are living with HIV. It's certainly been identified as a factor related to medication non-adherence, and some of the studies show that even small amounts of alcohol use can have a pretty big negative effect on adherence to medications. So one of the things that we see is that adherence is problematic for people who use alcohol for a variety of reasons. Probably one of the biggest has to do with misconceptions about the potential interaction between alcohol use and the medications. And what we hear from people a lot is, if I'm taking HIV medications, I shouldn't take them if I'm also drinking because somehow it will create some interaction that will be more negative to my health. And we've all heard this from physicians. We've heard, there are certain types of antibiotics that you can't take with alcohol. The idea of mixing, medicine and alcohol just in general in our medical system is actively discouraged by providers. So it's really no wonder that a lot of people living with HIV think, if I'm going to go out drinking tonight, it's actually better for my health to not take my HIV meds because I might risk some sort of weird interaction that could negatively affect my health than it is to go ahead and take my medication if I'm going to be drinking. What we know is that it actually is better for people to go ahead and take their meds even if they're using alcohol because the negative interactions are very minimal and really only for a couple of drugs that are very rarely prescribed anymore. But that type of information is not necessarily getting conveyed to people who are affected by it. There are some concerns, too, about the exacerbations of side effects from alcohol use. And a lot of times when you're working with positive men and women who use alcohol, they have a tough time differentiating certain side effects because there are side effects related to alcohol use and there are side effects related to HIV medication, and often they're the same side effects. So sometimes you're not really sure where is the source of the side effect. Is it coming from their drinking behavior or is it coming from their medications? And then, of course, there are the immediate cognitive and behavioral changes that happen when one is drinking, particularly when one gets to the level of being intoxicated. Your perception of time, maintenance of routines, all of these things which are related to successful adherence can be jeopardized while under the influence. So what we did was come up with Project Plus, and this was aimed at simultaneously improving medication adherence and reducing alcohol use behavior among heavy drinking positive men and women in New York City. And this was the team of folks who were involved. This was funded by the National Institutes of Health, specifically the National Institute on Alcohol Abuse and Alcoholism. And I want to sort of take you backwards in time to a study that actually led to this one in the first place. In 1997, we were funded to do a study focused on positive gay men and the connection between alcohol use and risky sex. And this was a study that we called Positive Choices. And take a look at this was our riveting recruitment card back in the late 90s and early 2000s. This was the extent of our graphic genius at our research center. We did get a little better, right, as we moved on. So we started to get more sophisticated in our recruitment materials and our graphics. And the reason I bring this up is because it's actually really critical in reaching people. This type of card, a lot of people are just going to toss in the garbage because it's boring, it doesn't really tell you what it's about, it's just plain bad. Whereas at least this kind of gives you some information, it gives you an indication of what the project's going to be about, and it's certainly more visually appealing. We also would tailor materials depending on the populations that we were after. So for example, this was our recruitment card geared specifically towards positive men who have sex with men. We had other recruitment materials targeting heterosexual men and targeting women. So we've gotten much more sophisticated about how we recruit participants for our studies over the years. We also found it very helpful to recruit in clinic settings, and to do that, to provide a more detailed brochure. One of the things that we've learned, particularly in New York, is that folks living with HIV feel a little bit like guinea pigs, and they feel overstudied, they feel like everything's a research trial, and we really felt that it was important to give them some materials that really explained what was going to happen to them in the study, and to try to sort of answer their question of, if I'm a participant in your study, what's it going to look like? What is the experience going to be like? And so we really tried to do that in a way that was going to be helpful and useful for folks. So to be eligible for Project Plus, they had to have a confirmed HIV positive status, they had to be on HEART, and they had to have an audit score of greater than or equal to 8. Now the audit is a brief measure of alcohol use and severity of problems. And a score of 8 is a score that indicates somebody is probably engaging in some hazardous drinking behavior. We further got specific in terms of they needed to be a heavy drinker. And based on NIAAA classifications, that's more than 16 drinks a week for men and more than 12 drinks a week for women. Now, these are standard drinks. And one of the things that we've learned is that you really have to explain that to people, because somebody's like, well, you know, I have 3 martinis an evening. Well, that's probably about the equivalent of 9 standard drinks. So a lot of people are like, oh, well then 16, that's really just a good Friday night. So because we were funded by the National Institute of Alcohol Abuse and Alcoholism, we also had to ensure that our participants had more alcohol-related problems than drug abuse-related problems. And I cite this in red as a major problem, because this is one of the sort of challenges, at least in the US, of working within different institutes of the National Institutes of Health. Because you have one institute focused on alcohol abuse, and you have one institute focused on drug abuse. And the institute that's focused on drug abuse doesn't really want to fund study focused on alcohol abusers, and the institute that's focused on alcohol abuse really doesn't want to fund studies focused on drug abusers. And yet this is a really sort of artificial distinction, right? The vast majority of people who are abusing alcohol are also abusing other drugs. And so for this study, we ended up excluding, for every 1 person that enrolled in our study, we ended up excluding 4. Because if their drug abuse problems were more of an issue than their alcohol, they weren't able to participate in the study. So that's sort of a challenge and a problem in sort of doing research within sort of an existing system that gets very specific about who it can serve. We randomly assigned participants using earn randomization, which is a computer-based method to ensure that you get groups that are equivalent on some of the key baseline measures. We matched them on gender, on their audit score, and on their CD4 count. And then we had two arms. We had the intervention arm, and then we also had an attention control, which was an education arm. And identify that as a partial major problem, and I'll explain why in just a moment. So they came in and we did a pretty detailed assessment. We looked specifically at adherence, since that was one of our primary outcomes. We looked at biological indicators of adherence, both viral load and CD4 count. And then we also obtained self-report data on their adherence using a timeline follow-back calendar. And we focused on the past 14 days. And some studies will just focus on the past 3 days for measures of adherence, but we really wanted to capture both weekdays and weekend behavior for adherence and for drinking, because we know that they can often differ. So for alcohol use, we also did the timeline follow-back, and from that we were able to obtain the number of standard drinks and the drinks per drinking day, which is a commonly used indicator of severity or frequency of drinking. But we did not have any biological measures of alcohol use. The challenge with biomarkers for alcohol use is, unless you take somebody who has significant sort of a long-term history of alcohol dependence, so that they have liver damage, basically, you have to get them to a long-term point of abstinence before you see changes in those markers. So it just didn't make sense to include those in this particular study. So the intervention itself, the first two sessions utilized motivational interviewing. And this is something that we've used often at our center as the kind of basis for interventions. It's very client-centered. For example, we would have our participants pick which behavior they wanted to focus on first, either the adherence or the alcohol use. We provided them with computer-generated feedback on their behaviors and would talk to them about how that might be affecting their health in the long term. And we also focused on the information component of the IMB model, particularly talking to them about the lack of connection between the interactions of adherence and alcohol use, to really sort of let them know that they could, in fact, take their medication if they were going to be drinking. We would have them formulate a change plan where they would talk specifically about the changes that they want to make, the reasons why they want to make those changes, and then the steps that they were going to take to make those. And we really let the goal come from the client. So if they just wanted to cut down on their drinking, that was fine. If they wanted to abstain from drinking, that was fine. If they wanted to just continue drinking at the same level but focus on their adherence, that was fine too. We really let them pick the goal behavior so as not to kind of force our agenda onto them. Then the last 6 sessions of this 8-session intervention used cognitive behavioral skills building. And we took sort of a menu approach to it, where the counselor would do a functional analysis to really identify for that individual client where were their skills deficits. And then we had modules that the counselor could choose from that addressed the most common deficits that we had seen in some of our preliminary work. So each client, although they got the sort of same number of sessions and the same approach, it was really individualized to their specific skills issues. So this is an example of the functional analysis where we would go over sort of what are their triggers for drinking, what are their thoughts and feelings, what kind of behaviors do they engage in, and what consequences do they experience, and then what function does drinking serve for them. And then the provider would choose 3 modules for each behavior. So we had alcohol modules focused on things like coping with triggers to drink, managing thoughts about drinking, refusal skills, moderated drinking if they wanted to just cut down but not quit drinking. And similarly for adherence, modules on managing side effects, modules on communication with healthcare providers, which was the single most commonly implemented module because that seemed to be the skills deficit that was most common in our folks that we were working with. And then there were also modules around sort of things that have to do with just healthy living, increasing pleasant activities, managing negative moods, sort of a kind of a mini depression module, if you will, making time for yourself. And these, they were able to apply to either behavior. The control condition also included 8 individual sessions with health educators. And for this, they would use videotapes focused on the same 2 behaviors, alcohol use, HIV, and adherence. And then they would engage in some structured discussion about those. And I say danger, 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 because this is a really powerful intervention in and of itself. And what we thought when we set up this study was we sort of viewed this as kind of treatment as usual, right? We sort of thought, well, most people who are abusing alcohol and are in HIV clinic settings, they're getting factual information from their providers or their social workers or their nurses or whomever about these kinds of activities. Come to find out that wasn't happening. So we were actually comparing what we thought was a very strong intervention to what also had the potential to be a strong intervention. This is the sort of flow of the participants in terms of who we ended up with. I'm going to present data on our 3 and our 6 month follow-ups. Our rates of retention were not bad. They were about 84% across the 2 conditions. And here's what we found. So we looked specifically at viral load and CD4 count from baseline to 3 month follow-up. That was our sort of most primary indicator. One of our sort of arguments in doing this was, it's one thing to change self-reported adherence, but if you're not having effect on the actual health indicators, it's not likely that a clinic is going to want to implement this kind of intervention. They're going to want to see actual biological endpoint results. At baseline, the 2 groups did not differ, so our randomization system worked. And at 3 months, we found a significant time-by-condition interaction so that our intervention participants demonstrated significant decreases in viral load and significant increases in CD4 count compared to those in the control condition. So to give you a visual idea, this is their log viral load. You see at baseline, the 2 groups were comparable, and then the control group saw a slight increase in their viral load, and the intervention group saw a significant decrease in their log viral load. Then for CD4 count, the intervention group over time saw a significant increase in their CD4 count, whereas the control group saw a decrease in their CD4 count. So we got significant effects on our 2 biological indicators. We also got effects on self-reported viral load, but again, that's sort of, I think, less critical than what you really want to see is did this affect their virology and their immunology. So for drinking, participants in both conditions actually saw significant decreases in the number of standard drinks over the first 3 months, and significant decreases in the number of drinks per drinking day. So everybody in both conditions got better about their drinking behavior. There was no significant interaction effect, so we can't say that those in the intervention condition reduced their drinking more than those in the control condition. So one of the things that we need to really consider is that attention control conditions in and of themselves can have a significant effect on changing behavior, particularly behavior that is relying on self-report. And there's a lot of reasons that this could be happening. It could be because just education is enough to reduce drinking behavior. It could be that just the act of participating in a study is enough to change behavior. Keep in mind, these people were coming in and doing these timeline follow-back assessments, which is basically like self-monitoring. And a lot of times the reaction we would get at baseline when they would look at the calendar and see how many drinks they had been consuming over the past 14 days was sort of a, oh my God, I didn't realize I was drinking that much kind of reaction. And everybody got that regardless of which condition they were in. So for some individuals, that may be actually enough, just kind of monitoring their drinking could have an effect on reducing their drinking. It could also be, though, that they're simply telling us what they think we want to hear. And in the absence of a biological indicator of alcohol use, we can't really be sure, did they reduce their drinking, because we have no health outcome to document that. All we can go on is their self-report. So at the 6 month follow-up visit, however, there were no more significant effects. So the effects that we saw at 3 months had winnowed away by 6 months. Still, the average log viral load and CD4 count did remain better in the intervention group, but not significantly better than the control group. So either one of 2 things happened. Either the intervention group sort of got a little bit worse between 3 and 6 months, or the control condition got a little bit better. But what it did was it washed out the intervention effects. Drinking remained lower in both groups, but again, there was still no interaction. We think the problem here is that there were no boosters. We're doing our interventions in a very sort of controlled research center setting. We are not direct providers. We're not providing ongoing care. So they would come in, they would do the intervention with us, and then we wouldn't see them again until 3 months. And then we wouldn't see them again until 6 months. Whereas our hope is that if we implement this in a clinic setting where people are routinely being seen by their providers, there's the opportunity for sort of built-in boosters to hopefully maintain those changes over time. So, this was the first published intervention to demonstrate efficacy for viral load, CD4 count, and self-reported adherence. Both interventions, though, the motivational interviewing, cognitive skills intervention, and the education intervention were effective in reducing drinking. And again, we probably need some kind of booster if we're going to maintain these effects longer than 3 months out. So how did we move beyond this study? So we started dealing with something in New York City that became known as the meth epidemic. You might have heard of it, right? In the first several months of 2004 was when we started to get a lot of focus on this, particularly among gay and bisexual men. This was on phone booths. Do you remember those? Y'all remember phone booths, right? We don't really have them anymore, do we? But these posters were on phone booths all over New York City. And the focus really being, there's this negative thing going on with crystal methamphetamine use that's leading to unsafe sex, that's leading people to seroconvert. And so we got, headlines in the news, gays' use of Viagra and methamphetamine is linked to diseases, said the New York Times. Crystal meth linked to AIDS in New York. The party drug increases HIV risk among gays. Rare and aggressive HIV reported in New York. We had that drug-resistant strain of HIV, which they attributed to meth use. And the whole party and play kind of mentality started to really get a lot of media attention and a lot of focus. And our own research at the time, we had been doing community-based surveys, started to identify a large increase in meth use among men who have sex with men. And we noted that the use was significantly higher among the men who self-reported that they were HIV positive. And there was also a very clear relationship between the meth use and the sexual risk. So we really felt a need to sort of address this. And so we also did some research that showed there was a relationship between methamphetamine dependence and poor adherence and increased viral load. So that sort of led us to think we can't just focus on the sex risk and methamphetamine, we also need to focus on the adherence. Plus, you have to think about the effects of meth just in general on the health of those living with HIV. So we felt sort of an urgent need to take our plus intervention, which was alcohol-focused, and adapt it to this growing epidemic problem of meth use for positive men who have sex with men. So we came up with ACE, which was sort of the child of Project Plus, if you will, and really took what we learned in Plus, tried to adapt it so that it would be appropriate specifically for positive men who have sex with men who are using meth. Again, like Plus, we're simultaneously trying to change two behaviors. In this case, we're focusing on meth use, reducing meth use, and increasing medication adherence. Similar to the previous study, it was an 8-session manual-driven intervention using motivational interviewing, cognitive behavioral skills, based on the IMB model. For eligibility, they had to have at least 3 missed medication days in the last 30 and at least 3 days of meth use in the last 90. They had to report sex with men and be 18. And we again used earned randomization, and we had 2 arms, the intervention or the education attention control. Right? Didn't I just talk about how an attention control can be a real problem? Well, it is a real problem, and at the same time, my argument was, if we couldn't come up with an intervention that did so much better than basic education, then our intervention really isn't worth it. And so we argued that we still needed to do that same type of educational-based attention control and not focusing on other behaviors. Some people will do attention controls where they focus on diet and exercise, for example. And we really feel like to test an intervention, you really need to compare it to something that they could be getting otherwise. They could be getting basic education about meth and adherence somewhere else. Same sort of recruitment strategies. We had a clinic brochure. We had recruitment cards. We like to show butts in New York, so we do. Obviously, we would not be using those in clinic settings, but so timing sucks sometimes when you're doing research. We identified the meth epidemic in 2004. The first ACE grant submission went in 2005. The second one, because you rarely get grants funded on the first round at NIH, went in 2007. It was funded later in 2007. By 2008, the rates of meth use had dramatically decreased among MSM in New York City. And in fact, in 2008, only 6% of gay men in New York reported using meth during the previous 12 months, which was a 57% drop from that reported in 2004. So what happened? Well, we had a lot of media-based campaigns around meth in New York. Lots of sort of things that focused on it, lots of treatment settings addressing the problem, lots of information education campaigns, lots of stigma-based campaigns. And so we were basically trying to find a needle in a haystack. And we still did the study. We completed enrollment, and we actually recently finished our last round. We did 15-month follow-ups with this sample. We ended up with a sample size of 210 after years of recruitment and literally trying everything. Now, the big question is, when we say that we saw a significant decrease in meth use among positive MSM, did that really happen, or did we stigmatize meth in such a way that people are just now not telling us on surveys that they're using it? And we don't actually know the answer to that. We suspect it's probably a little bit of both based on emergency room records of meth use and that sort of thing. Our analyses of this have begun, but right now the preliminary analyses are showing very similar things to what we saw in Project Plus, that we see a significant improvement in adherence in the intervention condition and not in the education condition, but we see a significant reduction in meth across both conditions. So where do we go from here? Because I have a few minutes left. So again, we tested both of these interventions in a very controlled environment, our research center at Chest. And we also had a lot of exclusion and inclusion criteria, which tend to be required when you're doing these efficacy trials and you're doing RCTs. Thinking back to the first one, to Plus, the fact that we excluded all of these people for whom drug use was more of a problem for them than alcohol use. The therapists that delivered Plus and the ones that delivered ACE were very trained. These were all individuals either with a doctoral degree or were in graduate school working on their doctoral degrees. They received extensive supervision because that was part of their training and actually part of their job. So the problem is, would we get the same results if we actually tried to do this in an HIV clinic, using the actual staff in an HIV clinic? Staff who are probably not going to have as much time to have such in-depth, ongoing supervision related to delivery of this intervention as we were able to do in our trials. So we submitted an application to NIAAA for a comparative effectiveness trial so that we could try to test Plus in 3 clinics in New York City. Our plan then is that we'll take the existing clinic staff in these sites, we'll train them in delivery of the intervention, and then we'll provide limited ongoing supervision, but we'll really sort of let them go and see how they do, how they're able to do it. There are also going to be very limited eligibility criteria. We're not going to, we made the argument that we're doing an effectiveness trial, we can't exclude those for whom drug abuse is a bigger problem. So we're not going to have the same sort of rigidness about our inclusion and exclusion criteria. And the fact that these patients are being seen in their clinic settings, we've got the natural opportunity for boosters so that we'll work with the providers to sort of revisit some of the content of the intervention each time the person comes in for a clinic visit. This project was funded. The trial is going to begin in early 2014. And that's all. We're doing questions.
So we're going to take some questions from the audience, but I wanted to ask one question first that I'm going to be asking of both of our presenters. So the first question for Dr. Parsons is, you kind of actually already addressed actually a part of that, which is that what most people think I'm going to probably talk about, which is how do we make this come to life in Ontario? Is it a clinic setting? Is it a clinic setting that's devoted toward addiction or HIV, because you're intending to make it towards HIV clinics, or to community-based organizations where a lot of us work. So I was just curious, what do you think are some steps that we could take if we were hoping to take some of your really great research and turn it into programs that could be implementable in Ontario?
Right. Thanks, that's a great question. My perspective is that there are different levels of intervention that are sort of appropriate for different settings and different types of patient populations. This intervention, it's 8 sessions, it's 8 one-hour sessions. It's a rather intensive intervention. It's a therapeutic intervention. It's also not for everybody. It's not for the person who just, has a beer on Friday night. It's for somebody who's really engaged in sort of heavy drinking behaviors. And so from our perspective, it's probably best suited more so for clinic settings or treatment centers than it would be for example, a community-based organization. A community-based organization, though, has a great opportunity to do the education type of intervention that we did, which we saw did actually have an effect on drinking behaviors. And so I kind of think that in some respects, the best approach may be kind of a triaging type of thing, where you take your folks who are the most problematic drinkers, you have them do the 8 sessions of therapy with a social worker. We're going to be training psychiatrists, psychologists, social workers, and nurses, all of them in this, so that sort of whichever person is seeing the person in clinic can deliver the intervention. But the sort of more intensive intervention for the folks who are really heavy drinkers being delivered by those kind of providers. But then education conditions can be delivered by peers. It can be delivered by health educators, a wider range of folks that may be easier to provide the training and supervision to in more community-based settings.
Thanks. So I'm going to take some questions from the audience, and there's one here already. Thank you.
Thanks. Well, maybe this is a dumb question, but it's about the alcohol study. You started out setting up the problem by showing that people, either because of their perceptions of interaction with alcohol use or because of their impairment, that there are problems with adherence. But then, at the end of the 3-month interval and the follow-up, their alcohol use in both arms reduced, but you showed the differences. So was the difference attributable to something related to the cause of alcohol, or because just adherence counseling was great in one arm versus the other unrelated to alcohol, and you didn't have an arm of people who were not overusing alcohol to see whether the adherence message was teased out differently? So what was the study about?
Right. Not a dumb question at all. So the situation is, our hypothesis was that drinking is related to non-adherence. And in fact, when we look at the day-level data from their calendars that they did in the assessments, on a day that they were drinking, they were 4 times less likely to adhere. But that's sort of only looking at days that they drink. If you look at days that they don't drink, it's not as though they were 100% adherent on days that they weren't drinking. So drinking drives non-adherence, but that there are other factors for which people will not adhere to their medications. So by reducing drinking in both conditions, why didn't we see an effect on adherence in both? It's because there are other factors related to non-adherence that we were addressing in the intervention condition that weren't getting addressed in the education condition. Things like those modules on how to communicate more effectively with your provider, how to manage side effects, those kind of things. We focused on that in our intervention. That was not a focus of the education condition. So even though education by itself can reduce drinking, that's not necessarily going to have a sort of perfect effect on adherence. Is it going to reduce adherence? Is it going to improve adherence a little bit? Yes, but it's probably not going to improve it enough to see virologic and immunologic changes.
Hi, this is a sort of a similar question. In the data that you showed that in the intervention group, the viral load went down, and the control group, the viral load went up, and then reversed for the CD4 counts. But at your 6-month intervention, there was no significant difference. Although you had some education for the control group, to what do you attribute that? It was a beautiful graph. It seemed a little... Do you know what I'm saying? Right,
and if you carry the graph out another 3 months, basically what you just see is you still see space between the 2 lines, but you don't see as much space. So basically, some people get worse over time, some people get better, and that happens equivalently in the 2 conditions to sort of start to bring more people back to that kind of middle ground.
My name is Matthew. I'm from Positive Youth Outreach. The question I have about you, again, about the alcohol. You mentioned that there wasn't a significant amount of adherence during the 3 months and the 6 months when it went up. The question I have to that is, you ever take into consideration that some people, when they start to cut down their drinking, they happen to binge drink? Did that ever come into a play by any chance?
Yes, and we did look at binge drinking in the data analyses, and as I said, like on a day that the individual drank, they were 4 times less likely to adhere. On a day that they binge drank, it was closer to 9 times less likely to adhere. So we do know that binge drinking is having a stronger effect on non-adherence even than just regular drinking.
Do you mind if I just ask the second question very quickly? You mentioned about the stigmatization about meth use and adherence. I mean, the truth lies in the U.S. that there's some pretty tough laws in America. Do you think for a second that this is driving people to go into the underground?
I mean, I definitely think that meth use has gone underground. I do think that people are less likely to talk about it. I think that people are less likely to be doing it openly. I don't know to what degree the laws around it are actually driving behavior. Typically, laws about drug use don't have a real strong effect on drug use behavior, so I'm not sure that's it. I have a feeling it's much more that, meth used to be used at, parties and clubs, and people were fairly open about their use, and then it became so stigmatized that we actually saw in one of our studies an increase in cocaine use among some gay men, and they would actually say to us, well, yeah, I'm using more cocaine now, but at least I'm not one of those meth users. And so they were actually increasing their cocaine use, but felt better about it because at least they weren't using meth. So does stigma reduce meth use? In some people, probably, but in other people, it probably just makes them a little more quiet about their meth use.
We probably have time for 2 shorter questions, and that's it.
All right. I'm Barry Adam. I'm doing a study interviewing new serial converters here in Toronto, and clearly a large component of that group are poly-drug users. I think it's a tremendous presentation. We need something very much like that here. But I was also struck by the socio-historical dimension of your talk, where you talked about how the meth wave had declined. And you mentioned some campaigns that have been going on at that time. I was just wondering, is that explanation of the decline of the meth wave speculative, or is there evaluative research? Because it often strikes me that we don't give the necessary time to social marketing campaigns and socio-historical dimensions of drug use, which may be, something significant happened there.
Absolutely, and I think there's a certain amount of speculative aspects to it. Certainly the Department of Health, who funded most of these campaigns, would argue that the campaigns are responsible for the decline in meth use. Again, I tend to look at sort of other factors like mentions in emergency room visits that are related to meth and how those did decline, but not to the degree that we saw declines in self-reported meth use. So did those sorts of campaigns work? Sure. Did they work to the degree that the self-report data suggests they work? I'm not 100% convinced of that. Related to the polydrug use aspect, I think that's a huge thing. And one of the problems that we have in doing this type of research, and depending on the nature by which you get funding to do this type of research, is oftentimes you experience what we did, where you're sort of behind the curve chasing the problem, right? We weren't able to get funding to address the meth problem when it was actually a bigger problem. By the time that a new drug may come and take its place. And so it's sort of difficult and challenging, again, when oftentimes our funding is based on, they want you to focus on one drug. And if you submit a grant to focus just sort of on drug use in general, people will be like, well, there's too much, variability, it's not, and so it becomes really challenging to sort of get on top of a problem as it's happening.
Yeah, Rick Julian. I'm currently working on a research project using peers and motivational interviewing to look at adherence as well, not just adherence, but to look at whether or not you want to start medication. So any guys who have a detectable viral load. two things. One, I'm really concerned about the fact that we tend to shy away of the complexity of what's actually going on when it comes to adherence, and we try to focus on, well, we'll just look at this one thing, or we'll look at this one thing. And I think we actually need to look at the complexity of it. I just had one quick question. In terms of tracking their taking of the medication, I saw the form for kind of tracking the alcohol use. What was done in terms of following their tracking of whether or not they took their meds? How was that?
Right, so we didn't use, for example, MEMS caps or an electronic monitoring way for their medication. We relied on self-report, and we used calendar methods for doing that. Because again, we were much more focused on what were the actual biological outcomes. Could we improve the viral load and the CD4 count over and above self-reported adherence? So we really didn't use sort of an electronic way of monitoring adherence like a lot of studies do. But related to your first point, the complexity of all of this around adherence is actually one of the reasons why I think peers using motivational interviewing are ideally suited to doing this. They're not then restricted by a manualized treatment. They're not necessarily restricted by the constraints of an RCT. They're able to actually address whatever the issues are as they come up. And we've done some research that have shown when we train peers to do motivational interviewing versus therapists, they're both equally good at delivering MI, but the participants actually like the peers better and engage with the peers more. Not rocket science, but one of the things that we were really happy with was we could show that with the appropriate training and supervision, we could get peers to deliver MI as effectively as therapists.
Thank you very much, Dr. Parsons, for your informative talk.
Thank you.
It's also an honor to introduce Dr. Conol O'Cleary, who will be presenting on a depression intervention to improve adherence. He's the Associate Director of Behavioral Medicine at Massachusetts General Hospital, Assistant Professor at Harvard Medical School, and Research Scientist at the Fenway Institute in Boston. Conol's research focuses on adapting cognitive behavioral therapy for integrated treatment platforms to support HIV prevention and treatment. Dr. O'Cleary.
We live in hope. Good morning. Here we go. So I just wanted to acknowledge Jeff's incredible work there and to mention some commonalities that we have up in Boston, running into some of the same difficulties treating crystal meth use. We've just finished an RCT. We just completed our recruitment for that trial last week, having had extended the recruitment period an extra 9 months because of ongoing difficulties identifying, even with considerable outreach into the gay and bisexual substance using communities, finding sufficient folks with crystal meth use. One of the things that we're finding too in our data, again, which I think mirrors the experience of Jeff's group in New York, is that there is a switch happening from crystal meth to cocaine. And one of the emphasis of the intervention we're working on is harm reduction, where even in the presence of continued crystal meth use, try and offset the damage it does to the health behavior that you're trying to target. And that harm reduction in the context of coke is an easier sell than harm reduction in the context of crystal meth. It's great to hear that we're making some of the same mistakes as Jeff is. So shifting focus a little bit, Jeff is talking about substance use and alcohol use and difficulty with adherence. What I wanted to share with you is a series of studies that make up some of our programmatic work up in Boston at Fenway Community Health and Massachusetts General Hospital, addressing depression in the context of managing HIV. Going back further in time than I would like to, this started with specification of a brief one-session adherence intervention was developed by Dr. Steve Safran, my senior colleague. This was originally specified, I think, back in 1999 and organized into one single session. It has its theoretical and conceptual base in cognitive behavioral therapy, and it's based principally on the problem-solving treatment component of cognitive behavioral therapy, where you identify initially people's goals for adherence, select motivated targets for behavior change around adherence, and then systematically through the lists you see here, identify each of the barriers that people encounter day to day, week to week, month to month, in terms of meeting those adherence goals, taking their medication on time, getting their medications refilled, dealing with side effects, trying to have effective communications with their provider and medical teams, and then introducing cue-controlled strategies to help with reminders around difficult and complex regimens. One of the early studies, again published in the early 2000s, showed good treatment effect for the Life Steps intervention. Again, in a very brief intervention, taking adherence up from 74% in the Life Steps condition to 94%. It should be noted that these were, as I'm sure most of you know, more complicated medication regimens requiring multiple doses and pills per day, multiple pills per dose, with fairly complex dietary and medication storing requirements. One of the things that emerged out of this study and related data collection efforts was the key impact of depression. Depression in this cohort was significantly associated with adherence, was also significantly associated with treatment outcomes, as were social support, punishment beliefs about HIV, and self-efficacy. When we entered all those into an adjusted regression model, the only unique significant predictor was depression. And what's interesting about this sample is that 3/4 of the sample had depression scores above 10. This places 3/4 of the sample in the clinical range of having depression, and 40% with scores above 20, which is above the severe depression cutoff. This was pretty consistent with some of the more influential meta-analyses that came out around the same time, indicating fairly small effects for simple standalone adherence interventions that maybe didn't consider some of the substance or alcohol use issues that may interfere, or some of the mental health issues that may interfere with adherence. A subsequent meta-analysis then, focusing more on just the RCT effects, found that adherence interventions were associated with patients more likely to achieve 90%, 95% adherence and above, and were more likely, although the effect was small, to achieve undetectable viral loads. And this meta-analysis by Jane Simoni didn't identify any particular treatment characteristic as being associated with any of these effects. A more recent meta-analysis by our team, taking a look at the impact of depression across a range of different chronic illnesses, found that among folks with HIV, depression was coming in at 36%, and that's compared to 7% in the general population, but also compared to other chronic medical conditions and other chronic patient populations managing chronic diseases, 36% represents a twofold increase. Some of the discussions that Jeff was having after his presentation, I think, get to a larger issue here. Certainly there are good reasons in terms of HIV disease management for for treating depression. It improves adherence, and in a perfect world, we'd like to think that those adherence gains would be associated with increased virologic control and maybe even improved immunity. But it's also worth remembering that there's a very rich research literature out there showing that depression is itself strongly linked to survival. People living with HIV who are depressed get sicker and die sooner than people who aren't depressed. There's rich literature out of North Carolina, Jane Lesserman's group, been following a longitudinal sample of folks with HIV for the last 20 years, and the effects aren't subtle. It's also worth mentioning that independent of adherence, treating depression in folks with HIV seems to affect some of the underlying biological mechanisms that may actually support improved immunity and improved immune function. Some of the work out of the University of Miami, those of you who are interested could check it out under Mike Antoni or Gail Aronson's work in the last 10 years, showing better control of latent viruses and more adapted ratios of cortisol and DHEA, some of these biological mechanisms that are assumed to underline immune health in people who are managing immunocompromise more generally. I wanted to take a little bit of a step back. Again, I think one of the things that Jeff reminds us of is that what we're looking at dealing with here is fairly complex. And I'd like to crave your indulgence for a few minutes and engage you in some complexity. Not that any of this is rocket science, but it is a little complex. This is one of our more influential behavior change models for those of us working in intervention development, the IMB model, where if we provide folks with information, we assess their motivation and maybe help augment their motivation for behavior change. We give them behavior change skills, and then we'll see behavior change in terms of adherence. The IMB model, it's called. The implication here is that change in adherence is mediated at the behavioral level when we provide some of the antecedent information and motivation level. Excuse me. One of the things about mental health and serious mental health and substance use difficulties that we run into is that they can affect each of these things: our ability to stay motivated, our ability to use the information that's available to us, and our ability to engage around behavioral skills to move towards behavior change of the health behavior we're interested in this case, adherence. The other double whammy with major depression and serious mental illness is that it just doesn't just interfere with these things themselves, but there's the strong possibility that it can interfere with the relationship between these things, and so maybe call into question the validity of some of our behavior change models. Again, neither today nor yesterday, Steve and other members of our team presented an empirical verification of the social cognitive self-efficacy model here. And again, what this shows is that some of the attitudinal precursors, beliefs about social norms, motivations towards disease prevention, and attitudes towards pleasure reduction, fold into self-efficacy, and how efficacious we are determines our ability to keep ourselves safe in sexual situations, i.e. use condoms. So we've moved here from looking at the health behavior adherence to looking at the health behavior condom use for the purposes of this demonstration. And again, we ask ourselves the same questions. What about in the presence of mental illness and major depression? How do these models fare in terms of the latent variables themselves and also in terms of the interrelationships between those variables? A couple of years ago, we decided to test exactly that. to take a look at the self-efficacy model. This was from data that we had collected at the Fenway Institute, screening for 2 secondary prevention trials, one a randomized trial, the other an open trial. And based on a sample size of over 400 folks from that data set, in this self-efficacy model, we tested the relationships between negative expectancies about condom use and perceived norms, social norms for condom use, how that was related to people's self-efficacy for condom use, and then how that related over time to people's engaging in unprotected, insertive, or receptive anal intercourse without condoms, which we referred to as sexual transmission risk behavior. So I apologize for the busyness of this slide, but essentially when you look at the sample as a whole, what you find here is that the model holds up pretty well. Negative expectancies and social models are each significantly affected to condom use, self-efficacy, which is in turn itself negatively related to transmission risk sex. So no worries there. Our models of health behavior change hold for the sample as a whole. And when we look at this, just restricting it to people who don't have major depression, the model performs even better. This is a good model that seems to account for the interrelationships between the main variables of interest that drive our conceptual model. And this is the whammy. When you look at these relationships and interrelationships in people with major depression, the model breaks down right exactly at the point where you would expect it to. Negative expectancies and social norms are still strongly related to condom use self-efficacy, but there is no meaningful relationship. The relationship between condom use self-efficacy and transmission risk is completely attenuated for people with major depression. So as we begin to look at developing integrated treatment models to address adherence or sexual risk in the context of major depression, one of the things we have to get real about is how useful our existing and traditional models of behavior change are. One of the places that takes me in doing this is reminding myself and you what major depression is. I'm a clinical psychologist by training, and in my clinical practice, every week I see what major depression is. And it isn't transient sadness when Battlestar Galactica ends, or it isn't even the kind of regret you might have when you split up with your boyfriend or break a nail. It's debilitating, overwhelming sadness in the presence of loss of pleasure and an inability to experience pleasure or take pleasure in the things that you used to take pleasure in, that it permeates every aspect of your life and your living. And it is associated around those two core experiences with some of the disturbances that are listed here, disturbances to sleep and appetite, energy and concentration, psychomotor retardation, and then a major cognitive component around feeling worthless and guilty and having thoughts about suicide or ending your life. A clinical supervisor of mine used to describe a major depression as the mental health equivalent of having 2 broken arms and 2 broken legs. So when you're talking about people managing HIV in the context of major depression, it's a fairly complex thing we're talking about. And I was interested to hear Jeff describe his intervention as bulky at 8 sessions. And he's right. In terms of HIV prevention and some of the HIV treatment interventions that we're looking at, it is bulky. But I'd like us to stop thinking in terms of 8 sessions to treat something like major depression or alcohol dependence or even crystal meth abuse. 8 sessions isn't bulky. It's the bare minimum of what we need to be able to address this kind of complex presentation. Similarly with major depression. So we specified across 3 different efficacy trials, and my colleague Steve published it in a treatment manual, a therapist treatment manual and accompanying client manual. This is structured into 8 to 12 sessions intervention to address adherence and major depression in the presence of chronic illness. Although our work on this has been specifically in HIV and diabetes. This cognitive behavioral intervention to treat depression in the presence of chronic illness, in this case HIV, this gives you an idea. I don't want to spend too much time on this, but for those of you who aren't familiar with cognitive behavioral interventions, one of the first things that your cognitive behavioral therapist will do will be to individualize your depression presentation in these 3 areas. The cognitive area, how depression poisons your thinking, how it infects the way you think about yourself, other people, and your future, can lead to self-hatred, can lead to hopelessness, thoughts about the future lead you to think that your friends don't like you. The behavioral component of depression, one of the central mechanisms by which depression does its damage in our lives is withdrawal. We tend to withdraw from the supports, from the activities that give us pleasure and meaning, and it tends to sap our motivation. And then the physiological component, which again can be a double whammy for folks with HIV, issues around energy and fatigue, concentration, sleep problems, problems with sexual arousal and satisfaction. These all overlap with some of these symptoms of advancing HIV. And in the blue boxes there, you see some of the main treatment components that make up our intervention, CBT-AD we call it, cognitive behavioral therapy for adherence and depression. Cognitive restructuring to address the cognitive component and its link to with behavioral withdrawal. Problem solving, specific problem solving training, not teaching people to solve any particular problem, but teaching them how to become their own problem solvers. Behavioral activation, kind of fake it till you make it. Even though you're not experiencing a great deal of pleasure, you need to have those activities in your life to reap the pleasure and mastery benefit that they'll provide. And then relaxation training provides a number of different curricular components to provide people with a menu of skills for achieving deeply relaxed states. And this is how we structure it. Initially, again, as I think Jeff alluded to, motivational interviewing is a key component. You want to meet people where they are. You want to be pulling for their own self-selected motivations for behavior change. We've fully integrated it into Life Steps, which is the 1-session adherence component. And Life Steps then takes up 10 minutes of each subsequent session. So those booster sessions that Jeff was talking about, all important. So this is a modular approach. This isn't necessarily a preordained order that needs to be followed. These modules can be switched around depending on your client presentation, what's going on with your client that particular day or that particular week. So the first RCT we did of this CBT-AD intervention was to estimate the effect size and to determine its acceptability and feasibility. So this was run at Fenway Community Health setting, meeting the needs of LGBT folks. Not everyone in the study were gay or bisexual men, but they made up 82% of the overall sample. It was a 2-arm RCT comparing CBT and Life Steps for adherence to what we called an enhanced standard of care. So everybody who came into the trial, regardless of which condition they got randomized to, the results of their full diagnostic assessment at baseline were communicated to their provider. So, hey, Dr. Smith, your patient, David X, met major diagnostic criteria for depression. He's not currently receiving treatment. That kind of letter. So not quite standard of care, a little bit enhanced. It was a crossover design, so those who continued to meet our inclusion criteria post-treatment were eligible to cross over. This was one of those, what was the word you used, Jeff? It was a rarefied treatment setting. Although it was conducted in a community health centre, we had very strict entry criteria. To get into this study, you needed to meet diagnostic criteria for depression. You needed to have adherence violations, as we called them back then, in the past 2 weeks. So we did, as you can see here, 300 phone screens. We did 118 baseline evaluations and ended up with 45 patients randomized and 42 completers. So we were really, it was a really circumscribed sample, which is what you need for initial estimates of efficacy. Again, to underline the complexity of what we're doing here, is that most people had comorbid mental health diagnoses, 64% of them, and 38% had more than 2 comorbid diagnoses. And you see the most common ones there, post-traumatic stress disorder at 31%. And over the course of 15 years and maybe with more than 20 samples in different sub-patient groups, people managing HIV, that seems to be the number for PTSD. It seems to be an even bigger problem in terms of mental health than depression. Social phobia coming in about twice the national norm, and panic disorder also. So how did we get on? Well, the intervention was associated with very significant increases in adherence as measured by MEMS caps, electronic data monitoring. And it was associated with significant reductions in depression measured by clinician diagnostic interview through the HAM-D. And interestingly there, you see those means on the red line in the center graph. This represents depression in the diagnostic range, and this represents depression below the diagnostic range, and no significant movement for those people in the control condition. CGI, another clinician-administered estimation of depression severity. Also, the treatment is associated with a significant effect. These changes in depression adhered over time. Those people who crossed over at T2, who were in the control condition, crossed over to the treatment condition. And we see their treatment gains for adherence and their treatment gains for depression too, providing additional evidence of the potential for an effect. Again, one of the things, although this was very much an efficacy trial with circumscribed inclusion criteria, the intervention itself was designed to be maximally flexible. So flexibility in terms of using the modules, flexibility in sequencing the modules, and also flexibility in terms of how much time was spent on particular modules. If somebody's a good problem solver, you don't need to spend 2 sessions on problem solving. If somebody is really in their head with their depression and really affected by depression-related cognitions and beliefs, you want to spend more time doing cognitive restructuring with them. The second efficacy trial we did was then to see if we could find these effects, not just in folks who are managing depression, but also folks who are managing heroin dependence. We also took this into methadone maintenance treatment clinics, which were the sites for this particular RCT. And the intervention, the CBT-AD intervention, was implemented in the clinics by our therapists. So you see the inclusion criteria here, being HIV positive, being on antiretroviral therapy, being currently in treatment for heroin or opioid dependence. This we relaxed our entry criteria around depression. You needed to meet diagnostic criteria for major depressive disorder, or you needed to have met it at some point in the past, be currently receiving psychopharm treatment for depression, and still have residual symptoms of depression. So we wanted to make it a little bit more real-worldy. The results of this study are published in JCCP last year, and the intervention was associated with a 10% increase in adherence, modest adherence gains, with fairly substantial decreases in depression to post-treatment. Adherence gains for the sample as a whole weren't maintained at 3-month follow-up post-treatment. We did a subsequent moderated analysis, and we found that the treatment gains were actually maintained for those who didn't relapse on substance use. For those who did relapse on substance use, they lost their adherence gains. We didn't find any difference in viral load across the conditions. The depression changes were robust. They large reductions in depression post-treatment that maintained during 1 year of follow-up. We also found significant differences in CD4. Those in the treatment condition had an average increase of 64 CD cells over the course of the intervention, while those in the comparison condition decreased. Again, in terms of keeping things real, so our treatment model here is that if we successfully treat depression, we'll get a bigger bang for our buck out of our adherence intervention. This is a schematic showing that mediation, the CBT-AD, the treatment-related changes in depression mediate treatment-related changes in adherence. So we subjected this to an empirical test to see if it was in fact the case. So the initial pathway, as I've just told you, the intervention was associated with significant increase in adherence. The intervention was also associated with significant decrease in depression. And when we do the test of mediation, putting them all into the same regression equations, we find that the primary pathway between the intervention and adherence becomes non-significant. The top line here, that the effect of the intervention on adherence is communicated largely through reductions in depression. This provides some good empirical support for our conceptual model and for the need to embrace this level of complexity. The results of these two studies were used to apply for an NIMH R01 efficacy trial, which we just completed last year. This is a 3-arm study. In addition to having cognitive behavioral therapy for adherence and depression, we had a time-matched control with individual supportive psychotherapy. And we also had a comparison to usual care. This allows us to ask some fairly important cost-effectiveness questions in terms of what's the actual ultimate utility and sustainability of this 12-session intervention. It's a big study. These are big, cumbersome studies. We randomized 240 people. For those of you who are going to the Association of Behavioral and Cognitive Therapies in Nashville later this week, you'll see a sneak peek at some of the baseline reviews. So just in terms of finishing up, just some of the take-home messages. Change is hard, and some of the pathways to change are complex. some of the things we've learned out of conducting these 3 efficacy trials is patient acceptability of these interventions, as long as we keep them flexible to the clinical needs of the patients as they show up for each session, is high. We can use CBT and CBT techniques to improve adherence, to address depression, in the presence of fairly substantial comorbid conditions, including heroin dependence. And some initial evidence, in our case on CD4, that we can improve and hit underlying disease process. And I'll leave it at that. Thank you very much.
So thank you so much, Conol, for your talk. We really appreciated it. I also wanted to kind of ask the same question that I asked Dr. Parsons, which is, you know, a lot of the research that takes place, it's very rigorous. There's a lot of resources behind it. They're very well-trained staff. And what do you think would be some steps that we could take if we wanted to implement this either in clinics or in community-based organizations like ASOs in Ontario?
Yeah, I was afraid you were going to ask that question. So we've had some success in various different settings implementing CBT-AD, cognitive behavioral therapy for adherence and depression, internationally in sub-Saharan Africa in some very resource-limited settings. I know that doesn't fully inform the question you're asking about the Ontario context, but we've just implemented this in Harare in Zimbabwe, and you don't know what resource limited means until you see what the folks over there, the incredible work they're doing trying to implement this, where there's, I think, 3 clinical psychologists in the entire country. And the idea that an intervention like this would be implemented by doctorally trained clinical psychologists is a joke. So we've spent some time over there training adherence counselors who would be at an educational level of high school graduates to implement a pared down version of these 12 sessions. So we've got a 6-session intervention. And we've learned some of that the hard way, where some of the techniques are a little too complex, not just for patients to take on board in the way in which treatment is delivered over there, but for the interventionists to learn sufficiently well to be able to impart in a therapy context. But I think part of the good news that we have is that we haven't yet met a setting where this can't be implemented in. In the second study I reported, where we actually intervened at the level of the methadone maintenance clinics themselves. In the efficacy trial that we've just finished, half of our therapists were master's level clinicians. The other half were doctoral level psychologists. 2 of the 3 settings in which the study was implemented were community settings. So I think that augurs well for implementability and sustainability in community settings here. I'm wondering, is Jane Simoni, are you in the audience? Don't you hate to do that? Somebody advertised the fact that you're not here. But I'd like to point you in the direction of an article that just came out in this month's AIDS and Behavior, where Jane and her colleagues adapted CBT-AD for implementation in a domestic resource-limited setting in El Paso on the Mexican border with in Latino immigrant communities. And it's a really elegant write-up of a great study, as I say, in the most recent edition of AIDS and Behavior. And I think that answers and asks all the right questions around implementability.
We probably have time for one question only.
Hi, my name is Wayne, and I ran to the mic because I have a question and I wanted to get it asked. I can totally relate to all of the information provided. I live with it daily, and to be brief, I'm going to read what I wrote because it was better, easier to put it that way. It's been very difficult for me to remain invested and continue with adherence to my own life's health and well-being. The unemployed, the uninsured, and the overwhelmed client is still very much so an alive and lived experience. And I've gone from gainful to literally quite painful in my life, from being empowered to that of feeling discouraged and hopeless. And while there, I was at my most vulnerable. It has been reinforced again and again at this conference, and I want to thank you for this, that the PHA is at the nucleus of our cell. And I forgot that before I came here. If adherence is what's required, so as to ensure continued good health and well-being of the PHA, how can we, and you beat me to the question, so I'll put it to my peers, how can we as peers ensure that agencies like my own, PERN, who wouldn't even give me $50 to come to this conference to pay my registration fee, after all the generosity that was put out by the taxpayers and OHTN to come, how can we, forgive me, for this conference, and other ASOs that are doing similar things in existence both here and abroad, how can we ensure that they start adhering to principles like those of JIPA and MIPA, the Ontario Recorder, just plain healthy ethics, so as to create an environment where adherence is made to be more realistic and an attainable goal? If adherence is what we're seeking, what else can we do? Because the information you're providing is absolutely true, it's bang on, but it's not a lived reality for PHAs like me that are out there. And there's more of us than, we'd like to actually acknowledge. So we, as a community, have to carry this information. But how? Because your stuff is not reaching me if I don't come here.
Yeah. I can't respond to everything that you said, the specifics of your local AIDS service organizations, but you hit the nail on the head. It's one thing to do these studies in rarefied scientific atmospheres. It's another thing to implement them in sustainable ways, to design them thoughtfully so that they will be sustainable. But it's a very, very different thing to actually getting them sustained and getting people access to them. Those are two additional areas that we're still nowhere on, I think. And those are the key questions. Thank you for your comment.
Well, thanks again to Dr. O'Cleary and to Dr. Parsons. We hope the talks were informative for people, and we hope that it will inspire us to do more work here in Ontario, including in our applied settings.